I made this slide on the aeroplane as well.
You're very productive on the airplanes.
Yeah,
Tom.
actually I'm good at planes. I should spend more time on planes. This slide gives a color-coded insight into ADC development in urothelial cancer. Enfortumab vedotin we know about, and I'm not going to go into too much detail around that. Obviously the targets there, the payload, the biomarker selection, ongoing randomized trials. So those are the only randomized phase 3s I put in, practice-changing randomized phase 3s. Grade 3 or 4 treatment-related adverse events. There's some grayness around TDXD, depending on you put the entire cohort in or just the 16 patients. Those little bars are response rates in refractory disease. TDXD only represents the HER3 positive patients. Disitamab vedotin, HER1 to 3 positive patients. So they're a bit unfair because they're biomarker selected, or some people might argue the way around saying they're really fair because we should be doing biomarker selected work, which we'll talk more about in a minute. And then bottom, the pie chart is associated with a combination with immune checkpoint inhibition in unselected patients. And the bicycle drug, well, I'll go through them. So we know enfortumab vedotin, which targets Nectin-4. Sacituzumab govitecan is TROP2 with topoisomerase 1. Disitamab vedotin is actually got the same payload as enfortumab vedotin, and that has a complication associated with it because there may be cross-resistance, and we're going to talk about that. TDXD is HER2 and topoisomerase 1. And these two drugs on the far right-hand side, I think those are the two least mature drugs. The first one is BT8009. It's called the bicycle drug because it has a different technology from the other drugs. And then BLB01D1, that agent is a HER3 EGFR Topo1 ADC presented at ESMO just recently, only data out of China available to us. So the first section of this is going to be around enfortumab vedotin. We're not going to talk for too long about that. We could do the whole session, but it's about drug development, not about where we are today. But I thought this poster from ESMO was one of the really important posters because here you can see a 40% 5-year OS in cisplatin-ineligible patients with urothelial cancer. We can also see on the left-hand side in the dark grey patients on therapy, but in the light grey there are lots of patients who are off therapy having responded to EV-Pembro. So it tells us two things. Firstly, it's not EV-Pembro forever. There is a degree of stopping therapy. Now there's an art associated with that, and a lot of that is currently driven by toxicity, and that's important to recognize. And then second, on the right-hand side, the EV302 results, the randomized phase 3 with a 50% reduction in the risk of progression, 50% reduction in the risk of death, 30% CR, 70% response rate, it's always tracked above the EV103. One of the unusual things was the randomized phase 3 outperformed the phase 1. And the reason why that was the case is this is cisplatin-ineligible patients, and so these patients are slightly less well-nicked than some of the patients that we put in EV-Pembro. But if EV-Pembro had a 40% 5-year OS, may or may not, but if it tracks this, how would that change our thinking of urothelial cancer? And Shilpa, let's start with you.
I think that will certainly point towards that we are curing a lot of patients. You know, historically 5% 5-year overall survival rates to over 40%, and that is just with frontline therapy is really remarkable.
Carla, what do you think about patients stopping therapy? And when you treat patients with EVP, what do you do? What do you say to your patients about how many cycles they're going to have? And you know, I come in, I'm sitting there thinking, oh my God, am I going on forever? You know, what do you say to your patients? I'm looking forward to responding. It's very important I respond. But how long do I need to have? How long am I going to be on this drug for?
Yeah, it's a great question, and I think that some of our real-world data might help to understand this a little bit better. I tell all my patients that there's a very good chance that they will be dose-reduced during the course of treatment. We saw data from Dan Petrolak showing that many patients get dose reduced. And despite dose reductions, we are still seeing responses. And the reason I do that is because I want patients to report toxicity, because they may not want to, precisely because they want to stay on drug and they want to keep their response going. It's really a cycle-by-cycle assessment. The main toxicities I'm looking for are neuropathy, skin rash, and diabetes. Those are the ones that I perhaps think about the most, but it's cycle to cycle, and then often I'm using low-dose steroids to try to maintain treatment. But I think there'll be a subset of patients that will get EV Pembro for maybe 4 to 6 cycles, but due to toxicity or other reasons may drop the EV and maybe go to Pembro alone, and maybe ctDNA one day will help us.
Andrea, you and I chatted about management of toxicity and baseline assessment of patients receiving EV Pembro. Which patients do you feel one needs to be cautioned before we start therapy, and how do you discuss toxicity management with the patients when you start?
I think we're still learning from the toxicity. This is a very unique toxicity profile, and as data matures and as more people use it, so I think that's why I really like databases, real-world databases, because they really help us. But I think we're learning. Patients that we have some concern about are hyperglycemia patients that have hyperglycemia. That doesn't mean that diabetic patients shouldn't enroll. And patients that have baseline neuropathy, that doesn't mean that patients, if you have baseline neuropathy, you shouldn't enroll. There was a really nice data set that was presented at ESMO as a poster on patients that had diabetes and patients that had baseline neuropathy and still received EV and still did well. So it's a matter of us learning how to dose reduce, how to manage the toxicities, stop it if needed, and then restart it. I think it's all an area that's evolving as we get more familiar with using this agent.
And in terms of managing the toxicity, Andrea, early skin rash, is that just a case of stopping the drug and peripheral neuropathy when it occurs? Are there any magic tips around that, or is it just about being very vigilant and stopping the drug very quickly when they occur and restarting at a lower dose?
Well, it's not all size fits all. So It depends on the level of the rash. Can you manage it with topicals? Do you need to include orals? Do you stop it and hold and kind of see? Because pembrolizumab can also cause a rash, like what's actually causing it. So, and then, what's the level of the neuropathy? There's also motor neuropathy, not only sensory associated with it. If the patient can't walk well, which has happened in some of my patients, they start getting kind of this shuffling gait. That's time to stop it and reassess. And most patients can be salvaged in terms of their toxicity with stopping and holding the drug, but it depends how much they've gotten. It is cumulative. So I think all of that, there's no magic bullet, but there are some very clear guidelines depending on the grade that you would give the toxicity as to how to manage those patients that are part of the investigative brochure and the guidelines that are out there right now.
Petros, how many of your patients get above 10 cycles of drug?
I would say that probably, first comment, the majority of my patients have dose reduction. I would say who makes it to 10 cycles, it probably depends, maybe a little bit less than half, about half patients or so. And almost all those patients have dose reduction. I agree with everybody that speak before me. I look for a reason to dose reduce, especially after the first couple of cycles. When I get a good control of disease based on Dan Pertilax data, I look for reasons to dose reduce, and I discuss with the patient up front that it's okay to have dose reductions. Do not underreport. Talk to us, let us know skin changes, neuropathy, fatigue, appetite, whatever side effect there is, because I think it will be relevant. It's a marathon, not a sprint, and those adjustments are critical to maintain this marathon. Reduction, delays, and sometimes occasional discontinuation based on toxicity-driven approach.
Nectin-4 is expressed in almost all urothelial cancer patients. The H score out of 300, so if you've got 100% of your cells staining, you get 100, and if they're staining 1+, you get a score of 100, 2+3, 200, 3+3. So to score 300 is actually quite difficult. It means all the cells staining a lot. If only half the staining a bit, you get about 150. And here the median is 150. I think this demonstrates that Nectin-4 in urothelial cancer seems to be quite closely correlated with each other. And the outcome data across the board in the EV302 study, I think it's fair to say that EV-Pembro outperforms platinum-based chemotherapy. Are there any patients, Shilpa, who you'd be choosing platinum-based chemotherapy over putting the you know, are there any platinum-based chemotherapy patients left?
Not really.
And what do you think, Petros?
I think Nectin-4 protein expression is not a good biomarker to select our patients. You showed great data, Tom, a couple of weeks ago at ESMO that there was no clear correlation with the degree of benefit. So the benefit applies regardless of the protein expression. But I would love to see more data. I applaud the effort of biomarker approach. The first time we saw biomarker data with enfortumab vedotin, so we like to see more data. I want to see maybe Nectin-4 amplification. There is some discussion about Nectin-4
We're going to come to Nectin-4 amplification here. This shows the relationship between PD-L1, Nectin-4, and outcome. And again, there doesn't seem to be very much there. So from an IHC perspective, there is no role to play. But there is some data kicking around on this Nectin-4 amplification. Andrea, who would anyone like to take on this issue? Because this work's coming out of the German group.
I think this is important. We want to make sure that the patient has the target and who are the patients that are going to respond the best. The only issue with biomarkers is, does that mean that if they have low amplification, we don't give it to them? Do we have something better? That means that they're going to do better with chemotherapy? We don't know that answer right now. So I'd say for now, this is evolving, and I think it's important to kind of really get into how to best measure the target in the patients that you're treating, but then how to use it, that's a second step.
If I can think of a renal cancer parallel, if I may, because this Nectin-4 amplification data is pretty immature, it's very small numbers, it's retrospective. The German group are doing, by the way, I agree, a great job, and it reminds me a bit of the sunitinib story. When sunitinib first came into kidney cancer, it was clearly better than interferon in pretty much everyone. And there wasn't a subgroup that you didn't want you to, we're going to give you interferon instead. Patients are not, the same with platinum-based chemotherapy. EV-Pembro has superseded platinum-based chemotherapy. And going out to fish out the 1 or 2 patients that can't have EV-Pembro, ending up with platinum-based chemotherapy with all the complications and the poor outcome, doesn't make a great deal of sense. But we did the same with sunitinib back in the day. We didn't develop those sunitinib biomarkers. And then when immune therapy came along, we regretted that. So I think that this is not about finding out who has chemotherapy in the future. It's when we talk about the new generation of drugs, about whether actually we can do better with those subgroups of patients. So we should be doing biomarker research. It shouldn't be about saying who doesn't have EV-Pembro. It should be about saying, let's learn for the future.
And I think it's also important to see how the variant histology patients do with that. So you're right, it does not affect our clinical practice, but it'll help us understand if the same therapies can be applied to non-urothelial cancer.
Petros.
So I was just going to say, and I think the fact that we don't need Nectin testing, we don't do or need PD-L1 testing to give something like EV-Pembro makes it a regimen that should be available quite broadly, like internationally speaking, because I know for us in Canada, doing biomarker testing is challenging. So to have a regimen like this that doesn't require biomarker testing is important. I think from a research standpoint, looking ahead, developing these biomarker assays and understanding where Nectin plays a role is important. But for today, we don't need this for using these drugs.
Petros.
Great point. Two quick comments. Number one, the mechanism of resistance to EV and other ADCs are very important. Also to define the next therapies, the therapeutic sequences that you might ask us, Tom, down the road with all those ADCs. Could we learn more to inform that discussion by understanding mechanism of resistance? And that will be a big ask, from the enfortumab vedotin program to look at that. And is the payload, is it the target, the antibody, maybe both, something unrelated? Would love to see more data in that. But Shilpa made a good point about histology subtypes and divergent histologies. We actually published some interesting data from our research autopsy series at the University of Washington Fair Heart Cancer Center. Our patients were really, amazing to, donate their body after they passed, very humbling. And we saw actually Nectin-4 expression in some histology subtypes like plasmacytoid and squamous. I know this is for your interest, Andrea. And this is, again, early data, but gives us some hints that the target may be there, not only in the classical urothelial subtype. More data, of course, are needed.
So let's summarize the EV story as we met at the moment. We feel that it is transformative and it has superseded chemotherapy, that there is a lot of education and training to be done around the toxicity profile. It's not necessarily more difficult than chemotherapy, it's just different. About half the patients are getting 10 cycles. Petros, are there any baseline characteristics where you wouldn't give EV Pembro to a patient and you'd choose platinum-based chemotherapy instead?
I used EV Pembro in the vast majority of patients. I have to think really, really hard to find patients who I may not do it. And this may be just very frail patients who wouldn't be good chemotherapy candidates anyway. Patients with ECOG PX of 3 or higher who may need palliative approach or potentially a checkpoint inhibitor monotherapy. Patients with grade 2 or higher neuropathy, that may be a challenge. And otherwise, it's hard to find. There is discussion about the diabetes mellitus, but we don't really know because those were not included in the trial. That does not mean they could not benefit. So we try to control the blood sugars and I try to give them
But you wouldn't, I mean, if someone had unstable diabetes, you wouldn't give them platinum-based chemotherapy.
I will still give
Right.
you the Pembro.
Exactly.
Yeah, you know,
Control their diabetes.
Right, what else
so you control
steroids?
their diabetes,
Right.
and there's no evidence that having diabetes at baseline predisposes
Correct.
you to that
Exactly.
hyperglycemia. And you
Quite
could
the
argue-
opposite,
quite the
Tom.
opposite.
Those who don't have
Yeah.
can get catastrophic.
We're going to move on to
There were
sacituzumab.
data from actually from ESMO, I think, Unite study, if I remember correctly, that look at these patients with diabetes mellitus and with neuropathy, and those patients could be treated. So I treat them. I just monitor very closely blood sugar and talk to endocrinology in primary care.
We're going to move to sacituzumab govitecan. It's the second drug which I wanted to talk about. And
Tony has.
Tony.
This is timely question. I'm sorry, but recently I think someone mentioned someone in our group actually sent me a letter published in European Urology about a model to exclude perhaps or include EV patient. It didn't have diabetes. It had HbA1c. I don't know if you're familiar with
Yeah,
it.
we
Tom?
actually wrote an editorial for
Okay.
that. And-
It has merit, yes, no, etc. If you want to comment on it, because I've seen this, noise all over.
So so there was an editorial that was written about a criterion for treating patients with EV plus Pembro, and we wrote an editorial about this because we felt really strongly that we're not there yet, and I don't think it was necessary because we don't have that experience yet, and a lot of the criteria that were being used really didn't have biological basis, like a creatinine clearance. We know that these molecules are large, not excreted by the kidney. So multiple different criteria, including hyperglycemia. I think right now, we should treat as many patients as we possibly can with EV plus Pembro because of the doubling of the overall survival. And we will learn as we go along how to manage these toxicities, just like we learned with platinum-based chemotherapy and all chemotherapy. So I think for now, and the frail patients, even some frail patients, I want to start them with like a lower dose. And my pharmacist is like, well, let's try a normal dose and see how they do, and then dose reduce them. And we've done that with a few of our patients anecdotally, and they've done okay. But I do think we need trials for frail patients and understand how to best manage them.
And I want to add that in those criteria that were proposed, like baseline rash, that could be from anything. That doesn't mean they'll have EV mediated rash, just like we use TKIs in kidney cancer all the time with patients who are on 3 antihypertensives. We just have become better internists managing blood pressure. We don't withhold life-prolonging therapies.
It feels like having a series of strict criteria that aren't necessarily related to the drug is sailing in the wrong direction.
I agree.
Agree.
We all agree, I think, in that.
I think we all agree on that.
Yeah.